Hospitals Medical and Professional Affairs and Information Technology Committee. Just wanted to let everyone know, if you see the lovely screen here, we have Sally Hernandez Pinedo is participating virtually. Good morning, Sally. She's in a listening capacity. And morning. Thank you. And so what I'd like to do first is to propose acceptance of our minutes from the November 20th, 2023 meeting. To have a
So moved.
thank you. We'll go each individually. Dr. Pagan?
Yes.
Dr. Katz? Ms. Lowe?
Yes.
All right, minutes carry. So we have our first item. Dr. Mendez will be introducing to us.
Yes,
Thank you.
it's a resolution for cabling services. I'm actually presenting for Jeff Lutz today. He'll present at the full board. I'll start out with the resolution, which is authorizing New York City Health and Hospitals Corporation, the system, to execute agreements to create a pool of vendor contracts with each of the following vendors: Forerunner Technologies Incorporated, Mason Technologies Incorporated, Coronet Corp., and Interface Cable Assemblies and Services, ICAS, for the provision of cabling services on behalf of the system for an initial period of 3 years with 2 one-year renewal options, exercisable at the discretion of the system for an amount not to exceed $85 million over the potential 5-year term, and to permit the system to add additional vendors to the pool should the need for additional vendors arise, and should such vendors meet the same minimum criteria and receive from an evaluation committee a score of 7.25 or greater. Going to the next slide. So as an overview, an RFP was done to enter into a pricing contract with cabling vendors to provide all labor, equipment, materials necessary to structure cabling services and rack and cabinet solutions in order to establish a network connection between devices and the LAN and WAN systems throughout the enterprise. So this includes our MDF and our IDF, which is our distribution frames within the system. To provide services for both project and support-based needs with a not to exceed of $85 million. Estimates are based on historical and known spend along with projected projects. And this does align to the not to exceed amount from previous contracts. So we are similar to previous years. The contract would be for 3 years, as I mentioned, with 2 one-year renewal options, similar structure to the citywide contract. Working to ensure that this is in place by the fiscal year 2024, and also to ease supply chain process. And this contract will replace the existing contracts that we have with Mason, who had actually acquired G Systems, and also Coronet. We are seeking, this is the nuance part, additional approval to allow additional vendors into the pool should the pool of 4 selected vendors, which I'll go over those, become unavailable to meet our operational needs, by allowing any vendors that through the same selection process, the evaluation committee membership, and the same scoring criteria with a minimum of 7.25 or greater on the score. We can go to the next slide. I did want to outline, the overview of what that process would be. And this is in order to modify the vendor pool. Is a process similar to the standard procurement process that we followed. So it would be solicited. The solicitation will be posted on the city record. The same evaluation criteria will be utilized to score the proposals. The evaluation committee will be consistent with procurement policies. And will evaluate the proposals. Any vendor with a score of 7.2.5 or greater can be selected, and EITS will present the proposed award to the CRC, the Contract Review Committee, as well as to this committee here, MFPA and IT Committee. And the not to exceed stays the same. It does not change. Thank you. The next slide is the RFP criteria. You can see the evaluation committee is a blend of individuals across our system from EITS, as also from OFD. We are asking for 5 years, or did ask, for a 5-year experience with cabling services of similar size and scope within healthcare facilities. They must be certified or with all the certifications necessary to install our equipment. So this is the cabling as well as the closets that I mentioned, the racks, etc. Have a financial capacity of operating revenue of at least 10 million over the past 3 years, as well as meet the MWBE utilization plan. And you can see how the criteria is split up. And then I'll go to the process. Thank you. So here is just an outline of, from a timeline perspective, of the procurement process, when the application was issued and it posted to City Record. A pre-proposal conference was held. We also did a walkthrough through Kings County to show some of the different rooms that the vendors would be able to see, and then have a full view of what we expected. On 9/13, the proposals were due and were reviewed, and on 11/2, evaluation committee debriefed and submitted final scores. 2 out of the 7 proposals did not meet the minimum criteria and were disqualified. And below are the top 4, which is Forerunners Technology, Mason Technology, Coronet Corporation, and Interface Cabling Assemblies and Services, ICAS. To note, there is 1 new vendor. We have utilized 3 of the vendors before. We can have the review of those vendors from an evaluation perspective, and they have all been at or above satisfactory. In addition, we did reach out for the ICAS and did a reference check with those individuals. Several of our city agencies do use them. We can go to the diversity slide. Thank you. And here you can see that all of the 4 vendors either meet the 30%, and 2 of them are actually 100% from WBE. I think I got ahead of myself. I did the evaluation first. And I will conclude then with the final slide. Thank you. Authorizing New York City Health and Hospitals Corporation System to execute agreements to create a pool of vendor contracts with each of the following vendors: Forerunner Technologies, Mason Technologies, Coronet Corporation, Interface Cable Assemblies and Services, for the provision of cabling services on behalf of the system for an initial period of 3 years with 2 one-year renewal options, exercisable at the discretion of the system for an amount not to exceed $85 million over the potential 5-year contract, and to permit the system to add additional vendors to the pool should the need for additional vendors arise, and they will follow the process, the evaluation and reporting process that we provided. And I will close there for questions.
Thank you.
I have a question.
Hi.
Barbara?
I'm just curious as to, I would assume internally we did an assessment of what people thought were priorities. And how well did this group, these groups or the preferred group met those priorities?
You mean from previous evaluation? I would say yes, we have been satisfied or overly satisfied with their response to our prioritized needs. In addition, I will say new projects came up, and so flexibility was another essential part, of being on this contract. So and you can imagine even through areas, building up our new data center, which we'll report on later, as well as South Brooklyn Health, when it became the new, building versus Coney Island.
Anything special with the nurses that they can have in hand on any second?
Well, I will, not from the cabling, but what it does do is that it ensures that the rovers that we have are able to connect to what is called an intermediate, box, so that that data from the rover can actually go to the main distribution panel, framework they call it, that will allow the data to go back and forth into Epic. So it's the foundational things that we build so that the nurses and providers and ancillary staff are able to use mobile devices more freely, and that they interface and are interoperable with our electronic health record.
Yeah, I mean, even the nurses writing out the plan or whatever from their assessment, to have that, a little extra help to help them decide what would be important. And it'll help them be engaged in advocating for things that we don't have that would be useful as well.
And we do have the Nursing Informatics Council, so we leverage that as well to get input from our nurse colleagues. Being a nurse myself, I have an ear to that.
Was there any
Yeah.
questions, comments?
I was trying to understand how the contracts would be allocated among the 4 vendors, and I guess I was thinking, okay, so I figure that they see the projects and then they kind of do the work, then
Yeah,
you
I'll
go
let
out and
Barbara
get a,
speak
get
to
a,
it, but they
get a,
do bid
get
on
a,
it.
Yeah,
another
so
one?
we have a mini bid process. So after this contract, for every project, we do a mini solicitation where the requirements are sent out to all 4 vendors. They again bid on it with their proposal, and then we select the vendor based on the lowest cost because they're all MWB, they're satisfying that. So for every project, we do a mini bid.
And then after that, if you don't get anyone, then you go out and plan to
Yeah, so
follow the
generally
process.
in the past contract, they all have had, were able to satisfy our requirements, prioritize our projects. But yes, if we do reach that situation where they can't, then we would probably use this process that we outlined and go out.
Thanks.
Mitch, any questions?
No questions.
Yeah, so just to follow up on Jose's point then, so if there are, and also just based on past experience, how often it comes up that one of these vendors will not be able to supply what we're looking for, to the extent that might be, would that tend to be something that would be more urgent? And therefore, should we have sort of a bench of players that we've already sort of looked at, or do we need that? Or is it our experience that it's so unlikely that it's really just a contingency that's for urgent?
I would say the latter more,
Yeah,
that
it's
it's
been-
more of a contingency plan. I think because we did have experience last year with the acquisition of one vendor being by the other and then having limited, access, we wanted to build in a layer of contingency, but ensuring that we meet all of the criteria and that we would report, following that process to this, committee, this board, as well as to CRC. So there's transparency.
Okay, so the likelihood is if there weren't an ability to meet, it's not that we'd have an urgent situation where we now have to suddenly assess the scoring on
Dr.
another
Calavia,
group.
is if something happened and everybody was just filled with capacity, and then we had to go out and have a speedy, acquisition of services, that this would allow us that capability without doing a full RFP, which takes
Right.
months.
Okay. Any other questions, comments from anyone? All right, let's take it to a vote. Jose?
Yes.
Yes, Mitch?
Yes. Yes.
Barbara, thank you. And myself as well, so it does pass unanimously. Thank you for that.
Thank you very much.
All right, and we can move on then to the Chief Medical Officer report.
Good morning. 2 comments before we actually go straight to our presentation. This is Black History Month, just to remind everybody the remarkable work and notable accomplishments of many of our African-American staff. Just want to mention that, as well as our history. And Saturday, February 3rd, was National Women's Physicians Day. It's always every year on the birthday of Elizabeth Blackwell, who was the first woman who actually became a licensed physician in the United States. Having said that, I'm going to ask Omar Fatal to report in on access to care among the pillars. Today, we're focusing on access to care and behavioral health. So, Omar?
Good morning, everyone. So just recap on some of the highlights related to access for both inpatient and outpatient and behavioral health in this past year. Starting with the workforce, because that's obviously essential to be able to have access, is we need people to be working in our system. So we were successful in distributing $1 million in debt relief grants to 27 providers. That was the initial gift that we got from one anonymous donor. And this past year, and thanks to Dr. Cass's advocacy, we were able to secure an additional $4 million in gift from another donor to extend this program by 2 years and double the number of providers who can benefit from it per year. And focusing on inpatient access, we were able to meet the state mandate to restore 225 psychiatric beds across 6 facilities. These were beds that were closed since COVID and during COVID, and our capacity at this time is around 1,000 online beds. And special thanks to nursing and Natalia for their help with that. It took a lot of effort from so many different teams to make this happen. And part of these 225 beds is the King's Extended Care Unit, which is a unit where people can stay for up to 90 days for rehabilitation and learning how to reintegrate back in the community with focused on improving housing condition. The ECU at King's is modeled after the ECU at Bellevue, which opened in 2020 and has been very successful. And we're currently looking at opening a third one at Elmhurst. And it also includes the D11 female forensic unit at Elmhurst, which has been closed for 4 years. And it just opened on January 22nd. And then shifting to outpatient and community access, we were able to expand our services for survivors of domestic violence by providing mental health services in 9 domestic violence shelters, but also established 2 clinics, one at Lincoln and one at King's, where some of these people can, if they choose to come to us, they can come to these clinics, and we have telehealth as an option in between. And for our regular outpatient visits, we have been working on adult mental health access across the 11 acute sites, and we have been focusing on EPIC, specifically visit types and workflows to improve efficiency. We're able to increase provider booking by 20%, which resulted in a 6% increase in patient volume in 2023.
The number of beds now that we have that are staffed, is that now our max? Are we fully staffed as far as the
So
licensed beds, let's put it that way?
we have more licensed beds than online. So there are no standard definitions, but we call online a bed that's available to put a patient in it. It could be offline for lack of staffing, or it could be any other reason, like clinical reasons. If there's an aggressive patient, we block other beds, or someone with COVID, we block beds. So there are so many other reasons why we don't have full capacity, but staffing is the number one reason. So we have 1,000 beds right now that are available for patients to be in them immediately. And the number of beds that we have physically available is around 1,140. So we have more beds that we could, yeah.
I was just wondering, particularly for women with children, I had experienced the need for them to be part of a support structure after their discharges and such, so that they don't fall back,
Mhm.
you know, either into drugs or some other kind of maybe lifestyle that affects their well-being. So I was just wondering if we are looking at the next tier of post-discharge and how to keep them engaged for a good while until they're totally on their 2 feet.
Yeah, and these are specifically women who you're talking about women who we see like in our OB practices or in women's health, or just in general?
I think there's a commonality for a lot of women who need to have some post-care support and such.
Yeah.
So maybe they could fly on their own after a while, but initially post-discharge, I was just wondering if
Yeah.
there's
We do have a focus on women's health in collaboration with Dr. Wendy Wilcox, and through the Impact 321 program and embedded services in women's health. And that's where because a lot of these women, I don't want to speak for Dr. Allen, or Dr. Wilcox, but they don't come to behavioral health. So I think our approach has been to meet them where they are, which is usually in women's health, and provide the services there, and then link them with outpatient services.
So we've actually have a focus of increasing our social work support and presence in our prenatal services, and with the backup. So there's a fellowship called Reproductive Psychiatry for psychiatrists who are interested in caring for women. And Bellevue has that fellowship, and so we have access to behavioral health specialists with a focus on women's behavioral health. And I think Dr. Uju Berry, which he's mentioned in here, actually is providing behavioral health services within our domestic violence shelters. So that's another population of women as well. We work very closely with behavioral health as well as pediatrics, starting with the care of the child while it's a fetus, while it's gestating, knowing that the care of the mother and the health of the mother really has significant impact on the development of the child, and providing there's a risk tiering system in the prenatal setting, so we can identify those at-risk families and provide not only care within the facility but in the community as well.
That's wonderful. Thank you.
Other questions, comments? Thank you so much. Excellent report. Dr. Sinaias, Chief Nurse Executive Report. Thank you.
I'll just, Natalia Sinius, Chief Nurse Executive, thank you so much for welcoming me. I'll just highlight one from my report. We have several accomplishments in nursing. I'll focus on the Care Delivery Daily Management System this morning. We just actually completed Bellevue, but within this report, we had successfully completed the Care Delivery Daily Management System implementation at Elmhurst last November. Elmhurst is the sixth hospital to complete the CD Squared training and rollout. The goals of CD Squared is really to enhance patient safety, to standardize communication huddles from, I would say, not top down, but from frontline staff all the way up to the CEO of the organization, to improve communication amongst nurses and nurse leaders, to escalate any issues for awareness and additional support, to organize and establish consistent nursing care that is patient-centric, and also to reinforce the nursing process and standard of care. This is a week-long didactic training that comprises of 5 service lines: medical, surgical, behavioral health, critical care, emergency medicine, and maternal child health, followed by simulation training for all nurse leaders, and then a rollout on all of these respective units. It's a great accomplishment. So far, we've seen an increase within our nurse communication scores and a reductions of falls throughout all of the hospitals we've rolled out our Care Delivery Daily Management System. Really proud of this work and looking forward to completing it this month at Bellevue as well. Any questions?
Natalia, it's not a question, but I was just saying how impressed I was that for several years I can think of many meetings of nurses that I attended that were focused on recognition, which is much needed.
Yes.
But I think this was the first one I had ever attended that was focused on a subject matter,
Right.
where you brought together all of the nurse leaders across the system to talk about a common issue of falls.
Yes.
And I thought that was terrific. You know, I think that's a great way of improving care across. It's a nice way. It's nice also for people to interact on their discipline, not just, it's so nice that you're also being recognized.
Right.
Right. Because I feel like when they're interacting around their discipline, right, it sort of reinforces professionalism and the sense that we're all here to prevent falls. And
Yes.
I thought it was great, and I hope there are other, you know, in the future, other meetings like that that you host that are focused on sort of specific nursing issues.
Thank you. So Dr. Katz is he's focusing on the fall summit that we had. It was excellent. Your presence mattered. We're also focusing on where we're not doing so well in terms of surpassing national benchmarks. And so we're implementing best practice. We're actually going to have part 2 of the fall summit in March. So we'll be implementing all of best practice because there's opportunity there with falls with injury and falls in general. So it was great dialogue, and they're really excited to implement best practice.
People seemed very motivated, very interested. Right. It was really a wonderful event.
I take this as a metric of how well we're doing as an organization. I think that nursing in the past have taken the brunt of falls particularly. And so the disclosures and such weren't so readily forthcoming, even though they would do their due diligence to write up stuff appropriately. It's a healthier organization when there's that kind of disclosure and support.
You're absolutely correct. We used to report 3 metrics, and now we're reporting 63 metrics across all of the 11 hospitals.
I love it.
So full transparency, because they're excited that and empowered that they can make a difference. Thank you.
Thank you.
I was trying to get a sense of CD Square, what it does, and how that training with nurse leaders worked. Just
Sure.
trying to visualize.
Sure. So
The
it's
nursing
essentially,
leaders, yeah.
it's going back to basics for nursing practice. So there are 5 days of training where I actually lead the training. It's a safe space for nurse leaders because if you think about it, there are nurse leaders with all sorts of different types of education, diploma, associate's degree, baccalaureate, master's, and doctorate. So we're all in a room and we go over what we've all learned in nursing school. And then we challenge one another in terms of, are our nurses wearing their stethoscopes? Are they doing head to toe assessments? How are they documenting? And there's a lot of conversation in terms of the COVID RN, nurses who were trained during the pandemic that never touched the patient. And so how do we lead those nurses to ensure that they're practicing safely? So after the 5 days, we then take all of the nurse leaders to go back to basics with standard work. So ensuring that they really understand what the assessments are in their areas, and we have them really go back to the basics and actually demonstrate what a head-to-toe assessment is and different practices such as bedside shift report, medication administration, how to sit with patients for 5 minutes. So all of the leaders are trained. And so the CEO and the CMO at all of our facilities come in during the 5 days. And then we train our leaders in terms of how to huddle. We have new huddle boards with that. It's actually been a gift from a grant on all of the units. I know Sally visited Lincoln and Lillian Diaz mentioned the CD Square rollout at Lincoln. And so we train all of the nurse leaders how to huddle within less than 10 minutes in the beginning of every shift. And then there's a huddle that also begins at 6:45 a.m. for leaders, where the CNO dials in and gets report from the off-shift supervisor, and all of the leaders are there for 15 minutes to really understand what's transpiring within the hospital. So after that safe space of a week of a lot of training, so we're all on the same page in terms of nursing leadership, we then start training frontline staff. So right now we're training 1,500 nurses at Bellevue, one by one, in terms of what are the expectations of a nurse when they walk through the doors of Bellevue every morning. Do they have their tools? Do they have their stethoscopes, their scissors, like going back to basics. And then we really, after we train the nurses on their respective units, we then bring them into simulation as well. And so they go over all of their skills and then they begin practicing. And we have coaches for day shift and night shift. So we have someone on nights to ensure that the night leaders and the frontline staff at night really understand what they should be doing for patients. And then once that's done, we really start celebrating, going back to basics as a facility. And that training is intense, as you can imagine. There's a lot of, wow, I was doing that incorrectly, or I didn't understand that was the expectation. But then once we go live, after everyone's been trained, we then start auditing. So the leaders audit the processes through via a QR code, and we know whether or not the processes are happening. But then once we go live, that means every unit within those facilities are huddling at 7 a.m. for less than 10 minutes. All of the nurses are doing bedside shift report. All of the nurses are doing medication administration the right way, Kim, with barcode medication administration. We coach them. And so we're ensuring safe practice. And then we monitor, we provide feedback, we go back, and the units then do really well. So once we went live with Harlem first in 2023, and then Lincoln, so Chris Roker and his entire team visited Harlem. George opened his doors, and Keisha Wisdom, the CNO, opened their doors, and they're able to learn best practice from them. So that's how we've really been doing it. So we're at 7 hospitals now. We have 4 more to go this year. We're really excited, but essentially, once we're done, we know that every nurse understands the expectations of safe practice, and then we then embed it into orientation for the new nurses coming in. Because there's been a lot of variability in terms of how people practice. And so it's fun, it's exciting. I had a nurse just the other day at Bellevue who's been there for 35 years. Tell me she's never seen anything like this in terms of going back to basics and it being safe. So it's been a wonderful experience. Even forensics at Bellevue wants a huddle board now. The head nurse has been there for 44 years. Wow. So a lot of experienced nurses, we talk about turnover, but the reality is a lot of individuals stay a very long time here at Health and Hospitals. But it's important that whether you're senior or new, we're all practicing at the same level.
I think they are actually going to retire from our hospitals.
I think
this
so.
is a level of support that nurses probably craved for a long time, could not articulate it or identify the elements of what will keep them secure, feeling secure at the bedside. Yeah. And the development that comes from that and the input to us around what's a best practice.
We've seen a lot of nurses want to become nurse leaders now because they understand what it means to lead. That's an excellent point.
And they can't run away yet.
Right. No.
Put their nails and their shoes or something.
There's so many angles on this, on the nurse side and then the patient side and the safety side that
Right.
I'm sure the quality folks would
Oh,
have
Eric
fun
loves it. So he's visited the
thinking about this.
hospitals and he's seen the boards, and part of this is also what we call a well-being buddy. So one person every shift that just checks in on everyone. So that's part of the burnout research study that we'll be doing.
Well, and the leadership makes sense because I think historically, nurses associated leadership positions with scheduling
Right.
and disciplining nurses who
Exactly.
were not, which doesn't sound like a very attractive job, right? If that's what you think being a head nurse is that I get to write a lot of evaluations and I get to do a lot of forms
Right.
and I get to do the schedule, like why would anyone want to be a nurse leader?
Exactly.
Sounds like a terrible
So we
job.
talk about clinical leadership.
Right.
Do we know what's happening at the bedside as leaders? So making, so a lot of our hospitals now have protected time from 8 to 10 for all nurse leaders to ensure they're on their units and can provide the coaching and support to frontline staff to do just that.
Right, so if you felt like your job was that you were going to help 20 nurses today to do better,
Exactly.
that would be a job that one would want.
Not the punitive aspect. Exactly.
That's spectacular, really. I can only, I can't imagine that we won't see improvements, further improvements in quality measures and so on. And Dr. Pagan mentioned in patient satisfaction. It'd be great to make sure that people get the feedback as these things improve.
The tracking metrics.
So there's really a good sense that, wow, I really did accomplish something, as well as feeling great about what I do. So
The empowerment is empowerment around what they should be doing
Exactly.
on the regular. That's nice.
super. Any other questions, comments? Fabulous, great report. Thank you. And we're back to IT. So Dr. Mendez.
And I'll
report.
just add in,
Yes.
that we, it's great, the Nursing Informatics Council,
Mm-hmm.
I think at our last conference, which is why I think we were doing the nod to medication administration check, we actually had a research presented on that, and how we can leverage technology better,
Right.
and then we brought the rovers in as well, so it's, I just want to say congratulations to you. But on to EITS. So so what I've done in this report, which I'm not reviewing the whole report, is provided an overview of our goals for fiscal year 2024, as well as kind of done a year in review, some of the highlights of some of the key accomplishments that we've done. And I'd like to bring our eye to one or two very high pieces. The first one is is the data center migration, which as we might just to recall, it was a project timeline that started in May of 2021. We completed both, not one data center, but two data centers in just this last month in December 2023. We sunset SunGuard in September 2022. So we were over at QPS. We've completed that transition. And just recently, our other data center was actually up at Jacobi Medical Center. So we transitioned that over to Cyrus One, and that was completed at the end of last month. But what is going on now at Jacobi is we are transitioning the old data center, if you will, to new MDF areas, which is like a closet that we use, which is called the main distribution framework. So when you have a biomed device on the floor, it goes to an IDF, and then from the IDF, it goes to the MDF, and then it gets connected to the network, and it can put things back in Epic or, document and things like that. So we are building out that area to support Jacobi. So it's not like there's going to be a whole big space available there, but we are going to be transitioning that. So it really takes a village to move two data centers, particularly from all the business service lines, because that means not just Epic, but every other piece of the 2,000 plus software that we use across our system to do that. So very proud of that. This is the updated, thank you very much, version of our network. So we'll be using this as we move forward. And before I close, the two things, if I may, to highlight is that just from our enterprise support services, which we rely on 24/7 to answer any call anybody has when they need support, we have gone from 92% satisfaction to 95.3%. And we are benchmarking against ourselves because the average benchmark for the nation is 85. So that's been a really great achievement in that area. And then the last is really is our PMO, which is our Project Management Office. During COVID in 2020, you can imagine that we would have had a lot of changes to streamline our environment, to build reports out, to put an instance of ourselves at the Javits Center. We had a lot of what we call demands. They're actually requests, but the system uses the word demands. We had about 2,000, and that was a high mark for us. Just this last year, we had over 2,500 demands across our system. So it's a really phenomenal team. It comes everything from building out the new hospital wing building at South Brooklyn Health to some major transitions in Epic, some workflow changes, like Omar was speaking about, that kind of thing. So I wanted to just point out, the success of that team. And all the other areas are highlighted, in the package as well. So thank you.
Super, thank
There
you.
was a time where we had to put the boxing gloves on to get a little piece of equipment. But the fact that, Jacoby was the front leader for nursing IT, for a long time, and it was helpful,
And they have the huge sim lab up there too. So
yeah,
it's like,
yeah. So Denise was the CNO there, and when I was at Woodhall, I was like, we need to come and see what you're doing, and it was helpful. But we were just on the sidelines, kind of thing. But at least nurses saw what the capacity could be in the future. So it's very nice to hear all that's happening, and everyone has equity in access to IT to help with decision making, to document effectively and timely.
yes, I mean, one of the slides that I'll reference you to in the deck is on the governance committees that we have. Definitely clinical governance. We'll report on in the future. We have a new AI, artificial intelligence governance advisory. Sorry, not governance, advisory committee. So we'll be reporting on those.
And I still want to hear that the new residents follow the nurses like this. I'm sorry. No offense.
On the customer experience, I just wanted to know, like, do you have a sense of the volume when you hit 94%?
Yeah, we do
What is the volume
70
per
to
month?
85, thousand call it I think every month. So it's a huge volume. I think she has them there, but you can see it kind of goes up and down, but on average it's 70 to 80,000 per month.
70,000?
Yes. This is everybody in our system. It's Gotham, it's the skilled nursing facilities, it's all of our affiliates.
Pretty impressive. 94% means because typically the things that upset people is, number one, their problem is not solved. Number two, that is solved on time, You gotta hit both.
We actually put, it actually came from Finney, from this committee, that we put a customer satisfaction survey in place 2 or 3 years ago. And we've gotten a very good return on that. And it has led us to, automate a couple of things. We are looking at a virtual agent, so we will be able to, if you just need to, get your password reset, we can, put you in this line and do it a lot quicker. Where if you're having an issue, with Epic, we may have to escalate that to somebody who's in Epic. The person at the front line, call center is not going to be able to fix the Epic piece, but we can escalate it quicker. So it really has, it's been very data driven, and this, I'll just give credit to Angela Zumarin, who is our AVP over this area. Thank you.
Any other comments, questions? All right, let's move on to Metro Plus then.
Good morning, everyone. On behalf of Dr. Schwartz, I'd like to present a brief update. I've been asked to focus on one item. I can inform the board on the other items if we have time. And that is, as it turns out, on the collaborative model for behavioral health. Back in 2015, 2016, the state made a pivotal decision that individuals with serious mental illness who were previously managed by the state in a fee-for-service model would be managed by health plans, managed care organizations. And in the first 5 years of that initiative, MetroPlus made a decision to outsource the behavioral health portion of this benefit to a behavioral health organization, Beacon. And the board is familiar with that decision. In 2021, we made a decision coming to the H&H board to bring behavioral health services in-house. And that decision was made because as efficient as Beacon was in living up to the document of what the state wanted, it wasn't truly collaborative in that there was information that MetroPlus had on the physical health side that wasn't getting over to Beacon and vice versa, and that led to disintegrated care rather than integrated care, which belied the mission of why behavioral health services are brought into managed care. So in 2021, MetroPlus made the decision to bring BH services in-house, and one of the key aspects of that decision was to ensure that there will be strong collaboration between the plan and providers. Without that collaboration, Dr. Fatal mentioned earlier the importance of meeting patients where they're at. That's underscored 3 times for people in the behavioral health space because there is no ideal situation. You literally have to meet people in the community with their behavioral health condition if that's where they're at, or if they're admitted to the hospital to finally connect with them because you've struggled to meet with them in the community or over the phone. So to that end, if I could have the next slide. One more, please. We decided to create a model which took a few years and very strong collaboration with H&H and other providers that I'll mention to particularly focus on individuals who are admitted to an inpatient facility where there was behavioral health or substance use, to place care managers on site. We do that now at 3 H&H facilities, Kings County, Metropolitan, and Jacoby. But moreover, at the other inpatient facilities and indeed the substance use facilities, standalone substance use inpatient facilities like Cornerstone, ACI, Elevate, Urban Recovery, where we also have people on site. One of the initiatives that we've put into place are these community outreach pods. And that model requires a care manager or peer to meet the individual whilst they're admitted into the inpatient facility, get to put a face to the person that will be engaging with them in the community, first in person and then eventually telephonically. But making that connection, we thought, was very important in order to ensure there was strong community-based follow-up post-discharge. Often what occurs is that even though the best plans are laid out for community engagement with connecting people to behavioral health or substance use providers, those connections don't occur because there is a breakdown in the system. And that's not because of the patient. It's really because we failed to meet that individual where they were at, the additional support they needed. So what the pods do is, again, the day before discharge, certainly on the day of discharge, they meet the individual. They then escort them home, go over their discharge plan, and ensure post-discharge for at least 90 days that they're connecting with that individual using peers. We have 13 peers now who meet individuals in the community, take them to their appointments, take them to their SDH need issues, housing issues, etc., to ensure that there is widespread engagement post-discharge. One of the other things managed care plans can bring, and that was always the hope of the state by bringing the BH benefit under managed care, was to be at the lead in terms of information exchange. We often have a lot of information on the physical health issues with a member, where they've been admitted, and inpatient stays. And despite the increasing reliance on information exchange through electronic health records, that promise has not really materialized. So a lot of information that should be available electronically between EMRs just isn't there. That one particular area is in substance use, where there are additional restrictions that prevent that information from coming across. So with appropriate consents, we can then share that information with the inpatient facilities. And for us, the biggest driver, the biggest risk factor for non-engagement in outpatient services is not actually mental health, it's substance use. And so that extra piece of information shared with appropriate consents, I think does bring that mission, that vision and mission that the state had to create that level of integration. We also have access to pharmacy information. Despite a lot of effort, some of that information is still not present. Not that we know what was prescribed, but we have access to information of actually what was dispensed by pharmacies, and often that's an important piece of information. So on the next slide, this initiative really began in earnest in 2022, materialized in 2023, and you can see that in terms of the redesign for the first 7 months, 8 months of 2023, now going from left to right, our first goal was to ensure that individuals engaged immediately post-discharge after their outpatient visit, but certainly within 30 days, that there was care management engagement. And we would like to see what you see on the right, where you see the post-30-day engagement go dramatically much higher, statistically higher than it was pre the design of this initiative. We'd like to see that shift, as Dr. Allen, you mentioned at the H&H cabinet, we'd like to see that same shift occurring at the 7-day mark, where we really want to solidify that engagement in the community, not just for Medicaid beneficiaries, but for the people enrolled in HARP, the Health and Recovery Plan. These are individuals the state designates as those with highest behavioral health needs, highest mental health and substance use needs. But there's early promise in what's taking place. The next slide, please. This is engagement at one facility where we have on-site care management. This is at Metropolitan Hospital. And you can see that post-discharge, the 7-day engagement since the redesign by placing someone on site has increased by 38% in 7 days and 32% at 30 days. Next slide, please. That is leading to some other promise in terms of reducing readmissions, both for individuals enrolled in Medicaid with mental health issues as well as those in the Health and Recovery Plan. These are early signs. We have to make sure this is, there's no regression to the mean effect here. So we do have to follow these people out longer to make sure that this is a sustained impact of the model. But we do believe that the collaboration that now exists between the plan and providers, always the concept behind the decision to bring behavioral health services into the managed care benefit is being realized by this collaboration. I would like to mention just a couple of other initiatives that are more community-based but equally important. One is to ensure that individuals admitted to a substance use facility, one of the biggest challenges, whether they're admitted for detoxification or drug rehabilitation, is that if they're initiated on medication-assisted treatment, that treatment is not continued in the outpatient setting. For whatever reason, it just doesn't connect. And what we have now done is initiated, starting in January, but continuing for the rest of the year, a pilot program with one major SUD facility, Cornerstone, a pay-for-performance initiative such that they will get rewarded for starting MAT whilst the person is inpatient, and then to ensure they make their 7-day appointment, and that if MATs continue for another 30 days, they'll get an additional amount of money for that work. And that's the MAT initiative. And then the next model is around transition age youth. We know that individuals between the ages of 16 and 25, when they transition from sort of the child mental health model to the adult model, between the ages of 18 and 21, 90% of these individuals often disconnect from care. And so we are beginning an initiative that will come to fruition in the second quarter of 2024, and then continue on for at least a few more years. Starting in Queens and Brooklyn, we are working very collaboratively with colleagues at H&H in the pediatric space, transitioning these children into the adult mental health model. And I believe that, again, is the promise that the state had in mind when plans collaborated with providers. for this initiative. And then finally, one of the other aspects is workforce expansion. And sometimes that isn't just about more people, it's more people working, people working more effectively and increasing people's comfort level. And Project Teach is an initiative set up by the Office of Mental Health at the state to give additional support to pediatricians. Should they have somebody with mild to moderate mental health issues, that they can manage them themselves rather than have to make a referral out. And what the state has found is that that initiative that's been started for the last several years has had high uptake upstate, but not, interestingly, much uptake downstate. And so we're working now with H&H to bring Project Teach into the pediatric ambulatory space as a result of this initiative, trying to give them more ability to connect to psychiatrists that they can reach telephonically, and then they can essentially manage these individuals without having to make a referral for those with mild to moderate mental health issues to specialist mental health services.
Questions, comments, Barbara?
You know, this sounds wonderful. I'm listening particularly to you speak about maybe the fall away after engagement. I had the opportunity to work with kids in 7 community. Washington Heights was the most profound effect, but we didn't do traditional clinical interventions. We did some leadership, but getting the kids to go to the return of boxing at MSG was really profound for them. And I think that engagement has to meet them at another level, you know, that, they stay with us for a little longer. And out of a group of young men in Washington Heights who initiated some Give Back Guns, this is under the Dinkins administration. And so there are 3 officers in that same precinct today that they did not trust before. But the thing about that is getting real community involved, rather than them being harassed by police in the streets and so forth, and supported by mothers who march against gun violence and deaths of kids in their community. It's just the engagement of the community in the leadership role of stopping just what we wanted to stop. But they stopped it. But got to kind of cajole them a little bit and, you know, get them to do the things they love and which they don't have access to, like the return of boxing to MSG. Was powerful in itself. But giving guns back was a tremendous thing for them as well.
I couldn't agree more, and I think one of the other, the acronym HARP stands for Health and Recovery Plan, and in the adult space, a lot of the focus, indeed our focus in this model, is on the health side, mental health services post-discharge, and we've seen as a result of this shift, one of the other slides speaks about the Performance Opportunity Project that the state initiated for individuals who've had 4 or more inpatient or ER visits for mental health conditions, to see how well we as a plan engage with those individuals. And we were middle of the road as a plan, but at the end of 2023, we're the top performing plan in the state, not just with engaging people for a month, but into continued engagement at least 9 months out. But I think the area that needs to be focused on even more after the initial mental health or physical health needs are met, and that's, again, a strong collaboration that has to occur with providers and CBOs in this instance, is on the recovery side. Getting these individuals not only their mental health care and the physical health care, but then vocational support, educational support, and the health and recovery plan pays for that. But so far, the dollars spent, even though those resources are available, are modest. And they do have to increase, but it begins with getting trust of the individual and then giving them the community support they need for outpatient services beyond their medical and behavioral health needs, but into the social determinants and vocational support, and then even job support.
Good questions, comments?
I wanted to make a comment that sort of underlies all of this work. Dr. Shah has appropriately talked about the benefits to the patients. there's another benefit that's very important to me, which is how our clinical staff sees Metro Plus Health. And it goes back to the question of what's the purpose of a health plan? At the most basic level, a health plan has to pay the bills, establish the network, print materials, right? That's the basic, right? And the question is, a lot of people then feel is, well, then what value do you add? You know, and the challenge of adding value as a managed care plan is that in the current environment, take health and hospitals, if a particular provider has patients in 5 or 6 plans, each plan is different. I mean, you know this from your own practice. It's extremely hard for the plan to make a difference because the poor provider, okay, you have this incentive on this plan and this incentive on that plan, and it makes it very difficult. And I think 6 years ago, the reputation of Metro Plus Health was not very good in our own system. And I think people actually recommended other plans. And I think that Natalia, Dr. Shah have really changed that. And the more that doctors and nurses and others see the value of Metro Plus Health, the more they will in good conscience recommend it. You can't make them recommend it, but a doctor has the right to say, you know, this is the plan that I think would be best for you. And the person gets to choose. But if the doctor is making a recommendation, right, that's fine. And so I think that all of these efforts have really changed how people see Metro Plus Health. And it's also on our side, we try very hard to be the home for people who don't choose a provider, because the more we could have our Medicaid people covered by Metro Plus Health, the stronger the collaboration can be. And that can happen, right, 2 ways. It can happen because our providers in good conscience recommend Metro Plus Health because they genuinely believe it's the best choice for the patient, or we're particularly accessible to people who don't make a choice so that they come to us. I would really love, I mean, in an ideal world, because there are so many Medicaid people, I would, you know, resort them all and have us be all of Metro Plus Health. Not just because I believe in the plan, but because I believe that's what's really necessary if you want plans to add value. That it's just too hard, you know, and I didn't even talk, the plan has to work with all these different providers, right? So on both sides, it's not a very efficient model for trying to influence care, which is why I think most people identify with their provider and don't identify with the plan. But as Dr. Shah was talking, the plan does have key data, right? What happens outside of your network where you don't know, the ability to contact people, right? So if you can align them. So I feel like, you know, we've come quite a distance in the last few years. Again, I think it's Talia, Dr. Shah really pushed it. You know, there's still some more room for more collaborative programs, more that the average health and hospital provider sees Metro Plus as an asset to them in taking care of their patients in a way that is different than they view the other 9 plans that people randomly come in on.
Yeah, I think what you just said, in a nutshell, is really, I think, progress of where we have to get in the future when we talk about the collaboration, because there is actually a tremendous amount of overlap between what the plan wants and what the providers want, but unfortunately the communication has not always been there. And I think your point, which is the evolution that's gone on in Metro Plus, behavioral health is a great example. I mean, from this transition from Beacon to in-house has just been amazing, tremendously fabulous, you know, accomplishment. But again, to the benefit of our patients, and now we're seeing things like readmission and so on are going to be clearly impacted. So I mean, I think you really pretty much capsulized, I think, one of the big problems in the system, and actually how I think Metro Plus and the collaboration has really tremendously helped. Just had one question related to the, which post-COVID actually has become such a big issue, which is the telephonic and the virtual, and how it's fit in. Has it been a real positive, particularly in being able to get the contacts afterwards as opposed to physically having people come? And I do know some of my patients find it not as good because they don't have that direct eye-to-eye contact with their provider. So I get some complaints about that. But on the other hand, you're getting much better access and continuity. So just your sense of where that's
So
gone.
I think that in the BH space, once a connection has been made in a brick and mortar space, then for an individual with behavioral health issues who may actually struggle to leave their home because of their behavioral health conditions, then to be able to connect to that provider telephonically or audiovisually is a plus in terms of it may reduce no-shows. Can I leave my home where I'm going to face the community if I'm struggling with, serious mental health issues? You might say I'm going to do it from the comfort of my home, but I think making that initial connection may be where, if that's the first time you do it and that's the only way you do it, I think it might be a struggle. But I think you have to adapt, and I think the ethos of meeting the person where they're at, and if they want a telephonic visit, we can do that. We want an audiovisual visit, we can do that. You want to come in and see us, we can also do that. Is to create that adaptability is where I think telehealth has its place. And as a result of that, the state now has parity in payment, which is important because if you don't have parity in payment, they'll favor one modality over another.
Any other questions, comments? What's that?
Yeah, this very impressive work, this care management program. I mean, and because I think it gets into this issue of like sometimes when you run a service, any service, you because you do it so often, you think it becomes routine to you, and you forget that it's hard for people to navigate that. So if you multiply that by 10 services, and you have a person being discharged from the hospital, it sounds simple, but it's actually pretty clever to have a peer support specialist that is somebody that holds your hand and walks you around the system. So in that sense, it's the numbers that you have shown there on engagement and hospitalizations year to year. It looks pretty impressive. One thought I had on this that I was thinking about this is the peer specialists are spending time with these folks that get discharged for months, right? So I don't know if you thought about like how to get their feedback on the challenges that they still face when they connect folks, because they're the ones who are out there, and they're the ones who are going to be frustrated with the system, even though they navigate it with many patients.
Yeah, I mean, I think that's so astute because you have to, as much as they're supporting the patient, you also have to support the peer.
Yeah.
What are they struggling with? What barriers do they face when they're trying to advocate, and what frustrations does that engender in them that then impacts their care of the patient that they're also coupled with? And so we've had actually a number of instances where the peer has had major issues. There was an instance of a peer being what they perceive as not being properly treated by hospital security at a facility, and it did invoke a lot of their prior engagement with the criminal justice system, and it triggered thoughts and what they had not encountered for several months. They then encountered when they're trying to do the right thing, and then had to be treated in that fashion. So I do think their insights are pivotal and crucial, and we do elicit their feedback, and they do actually give us very concrete feedback about the challenges they face. And I do think that any model, and the 1115 waiver that we didn't get into focuses a lot on community health workers. That has to be, you talked about building in customer satisfaction. Let's also build in the sort of a model that surveils the peers and community health workers on their experience, because their experience will actually make our system better in terms of what our patients encounter.
Excellent, thanks.
Any other questions, comments? Excellent. Thank you all. Meeting adjourned. Appreciate it.
Forget you're not so in.
This meeting is no longer